Deep venous thrombosis, or DVT. The deep veins of the legs and pelvis usually perform well in their role of returning blood from the lower half of the body to the heart. The leg veins work in conjunction with muscular contractions in the lower extremities and also possess one-way valves that encourage blood flow toward the heart. However, in conditions such as prolonged immobilization, major surgery, severe injuries, stroke, cancer, advanced age, pregnancy, and the post-delivery period, use of birth control pills, smoking, long airline flights, and a variety of other situations, blood clots can form within these leg and pelvic veins and sometimes extend into the major vein of the lower body, the inferior vena cava, or IVC. This condition of deep vein blood clot formation, known as deep venous thrombosis or DVT, causes venous obstruction and can lead to a blood clot or embolus migrating to the lungs, an event referred to as a pulmonary embolus or PE, a potentially lethal medical emergency. Approximately 350 to 600,000 Americans are afflicted with DVT and PE annually, and of these, at least 100,000 will die. DVT can cause venous obstructive symptoms such as leg swelling, pain, and redness, although some acute DVT patients may demonstrate none of these findings. Long-term effects of DVT may include leg swelling, increased skin pigmentation, pain, and ulceration. This so-called post-thrombotic syndrome, or PTS, can occur in up to 50% of DVT patients and may result in permanent disability. PTS is due to damage to the deep venous one-way flow valves as well as chronic occlusion of the deep veins of the legs and pelvis following DVT. These conditions are not prevented by the usual therapy for DVT, anticoagulation with heparin followed by long-term Coumadin. In an effort to prevent the debilitating effects of PTS, IR physicians are now performing early intervention to break up and dissolve occlusive blood clots of the legs and pelvis using catheter-based techniques, usually within 10 days of the diagnosis of DVT. Usually through a puncture within the popliteal vein behind the knee, an IR physician will advance a device that will fragment occlusive blood clots while infusing a clot-busting or thrombolytic medication within the femoral and or iliac veins of the thigh and pelvis, respectively, to reopen these veins, relieving venous obstruction and helping to avoid damage to the venous valves. Sometimes, endovascular placement of a metal meshwork tube or stent is also required within the iliac vein to maintain patency of this vessel. These same techniques may even be useful in selected patients with more chronic symptoms of PTS. In some cases, pain, swelling, and or DVT in the left leg may be the result of compression of a pelvic vein by an overlying artery, a condition known as the May-Thurner syndrome. Balloon dilation or angioplasty and stenting of the affected left iliac vein treat this condition by holding open the left iliac vein and eliminating the blood flow obstruction within this vessel. IR physicians may also assist patients at high risk for PE due to prolonged immobilization. For example, someone who is about to undergo hip replacement surgery and who also is not a good candidate for anticoagulant therapy. In these cases, a small metal umbrella-shaped device may be inserted via either a groin or neck puncture into the inferior vena cava, or IVC, to prevent the migration of a blood clot from the legs or pelvis to the lungs. Many of these IVC filters are now retrievable weeks to months following their insertion, so that they can be removed when the risk for PE is no longer present. So it is evident that interventional radiology techniques and technologies can frequently address the challenging problems of pain, disfigurement, and disability facing hundreds of thousands of Americans with acute and chronic venous occlusive disease.